Good afternoon, Anuja madam.
Good afternoon, Ratan.
Ma'am, we'll start in 2 minutes.
ठीक है। हाँ, ये वाला गेट उस हेडर में गेट से जाइएगा मैम, ठीक है।
Good evening, everyone. Welcome to Mahamana Case Discussion Series. Today we have with us Dr. Anuja Deshmukh. She is professor in head and neck oncology from TMH Mumbai. Welcome, ma'am. And today she's giving a talk on genetic testing in medullary CA thyroid. Ma'am, can
Thank you.
Yes.
Yeah, thank you. Thank you, the course director and the organizing secretaries, giving me the opportunity to speak on this forum. Greetings from Tata Memorial Hospital, Mumbai to you all. I will be talking about the genetic testing in medullary thyroid cancer. As we all know that medullary thyroid cancer is different than the differentiated thyroid cancer. It is a more aggressive disease and there are not many trials associated with that. However, surgery is the mainstay of treatment. It is differentiated between the two types, that is the sporadic and hereditary mainly MEN2A and 2B syndromes. Coming to the MEN2A, there are 4 variants. One is the classical one, that is medullary, followed by sometime what you can get is a pheochromocytoma or hyperparathyroidism. Or you can have a medullary along with the Hirschsprung disease. Or you can have a cutaneous lichen amyloidosis. The fourth type has got some kind of a confusion. Some people think it is a separate from MEN2A, but according to the last ATA guidelines, it should be included as one of the variants of the MEN2A, where only MTC is the presentation of these patients. The familiar MTC, by definitions, there are different definition and criterias are used. That is more than 10 familiar members or more than 4 familiar members, or maybe like 2 generation or 2 cases in small family can also called as familiar medullary thyroid cancer. The MEN2B forms a 5% of the hereditary thyroid cancers of the medullary, and which is very unique phenotype which you cannot miss when you see a one patient of a MEN2B. So MEN2B is associated with non-endocrinal stigmatas. Those are oral, like having a nodules on the lip and the mucosal aspect, or ocular nodules like conjunctiva, corneal fibers thickening, ectropion, or intestinal ones where they have a pseudoherspring diseases, or a musculoskeleton like marfanoid habitus. So in a nutshell, what you have in MEN2A is pheochromocytoma, that is 42% penetrance. In MEN2B, it is 40% around, and hyperthyroidism component seen about 10 to 30% of MEN2A patients. And you have a different combination, what you can have it with other associations with the MEN2A. So coming back to the sporadic and hereditary, we know that sporadic is totally different than the hereditary medullary thyroid cancer. And the way they present is totally different. And even the survival, the 5-year survival and 10-year survival is far better than the sporadic. However, MEN2B has got a most aggressive disease, and the prognosis is little worst as compared to the familiar medullary thyroid cancer. So we need to know that they are different disease and different biology and how they present to us. What made it different from the differentiated thyroid cancer is the discovery of red proto-oncogene in case of a medullary hereditary thyroid cancers. And this discovery in 93 has detected the susceptible gene for this. And following that, there was a phenotype and genotype correlation which led to the prophylactic thyroid surgery in medullary, which made a remarkable discovery and the further future kind of planning system, the management for the medullary thyroid cancer. So if you look at the red proto-oncogene, that is the 10 chromosome, where on the long arm of the chromosome you have 11.2, you have a proto-oncogene point mutation. It is the mutation which is a predominant driver for this. It is a gain of a function mutation which changes the C cells, and this mutation is a germline. That means every cell of the body presents this mutation, and sometime it is present somatically also. That means it is in tumor also in 50% of the sporadic cases. You have a de novo red proto-oncogene mutation in 75% of MEN2B patient, and 6 to 10% of apparently sporadic cases you will have it. The inactivating of the germline mutation is seen in Hirschsprung disease, which leads to the congenital absence of the enteric ganglia. So how this inheritance is achieved? It is by the autosomal dominant. That means 50% of the offspring will have the chances of having the mutated gene in the child. The sporadic is about 75, 25% is hereditary, and if the index patient has a red mutation, then the genetic counseling or screening of the family member is required. So coming to the codons and the mutation present, the ATA has got a risk stratification. That is 918 codon positive mutation is considered as the highest risk. 634 and 883, which is the MEN2B component, is a high risk, and the rest of the all other codons are considered as a moderate. If you look at the red proto-oncogene, it has got a extracellular domain, and it has got a cell membrane and an intracellular tyrosine kinase 2 domains, the 1 and 2. And there is a cysteine rich region. So whenever you have a MEN2B, it is the 16 exon 918, it is considered as a high risk, and 11, that is 634, is considered as high, and 883 is on a exon 15, which is again an intracellular tyrosine kinase domain, that is considered as a high risk level for the medullary thyroid risk factors. And the rest, all other codons mutations are considered as as a moderate risk. Earlier, it was considered as A, B, C, and D. Now, A and B are clubbed to have a moderate risk alone. So, who should undergo genetic testing? So, all patients with a medullary thyroid cancer should undergo a red proto-oncogene mutation study. The first degree relatives of the patient with a proven hereditary MTC. The parents whose infants or the younger children have a classical phenotype of MEN2B. The patient with cutaneous lichen amyloidosis, an infant or the young children with the Hirschsprung disease with exon 10 red germline mutation, or adult with MEN2A and exon 10 mutation and who has a symptom suggestive of Hirschsprung disease, all should undergo genetic testing. So what are the advantages of doing genetic testing? We were not doing it a couple of decades before the genetic testing for all, but we know now that there are advantages. That is, it detects the risk long before the serum calcitonin gives you some values. So it is before biochemical changes, and once in lifetime identifying the mutation carrier instead of doing the biochemical test every yearly. The abnormal serum calcitonin also can be seen in other condition, which is not necessary that they are harboring the medullary thyroid cancer. And also high serum calcitonin levels are seen in the young children less than 3 years. It also helps to work up the patient with associated endocrinopathies, that is hyperparathyroidism and association with the pheochromocytomas. Also, if you have an age-related tumor progression from C-cell hyperplasia to medullary thyroid cancer to neck nodes and then distal mets, this strong genotype-phenotype correlation helps to prognosticate. Knowing the mutation, you can help age-directed progression pattern, and you can optimal timing for the prophylactic thyroid surgery can be suggested for the patient. Furthermore, it predicts the approaches to the surgical management. So somatic mutation with red proto-oncogene, the mutation has got an advanced stage, higher recurrences, persistent disease, and poor survival. So the surgical approach will be more aggressive for the patients which the mutation if it is aggressive, and the chances of cure is more if you identify the genetic mutation and act on it. Also, somatic mutation can be used for using some kind of a systemic therapy for these patients in a later date when they have a metastatic or an unresectable disease. So it's a future direction for the medullary thyroid cancer. So there are different nomenclatures are used when you see the report of a red proto-oncogene mutation, that is causative MEN mutation whenever there is a clinical expression of the disease or a family positive. Polymorphism is labeled when there is a benign germline red sequence is detected without having a causation with the MEN2, or a variant of an unknown significant is seen when the disease or a clinical information is insufficient to correlate with the disease manifestation. And these are the different terminologies are used to report the red proto-oncogene in a patient. So coming to this one of the reports of our one of the family who has got a 634 mutation in axon 11, and this is the mutation which I am talking. If you can see, it is an extracellular domain, cysteine rich domain where you have a 634. This is the high mutation, and this is the way we report each patient after proper counseling and confirming the report. The report is handed over to the family. So what are the other options with the red mutation carrier? So prenatal testing is also available, that is first trimester or second trimester doing a testing and then on the blood test, so that you can use and analyze this point mutation in a particular patient so that you can detect in a prenatally the positivity of a red mutation. You may detect pre-implantation genetic diagnosis, and this actually helps to eliminate the mutant embryo and replace it only by the allowing non-mutant embryo in the body, so that implanted in the mother, so that you eliminate the disease gene from the family and have a high pregnancy rate. And these are the two future reproductive options for the RET mutation carrier patients which are available. However, there is a lack of participation because of the surgical intervention is possible, and there is a substantial amount is involved with this kind of a intervention. Therefore, there are not many takers for these kind of options. So coming to the last part, that is the usefulness of the genetic testing for doing a prophylactic thyroid surgery. So prophylactic surgery for any cancer is basically a removal of an organ prior to the malignant transformation while the cancer is in situ or a asymptomatic individual. And this is a age appropriate surgery which reduces the disease recurrence. And there are certain criteria that is given by you et al, which is fulfilled by hereditary medullary thyroid cancer. And these criteria are, there are 5 criteria, and medullary thyroid penetration is 100%. We have a red proto-oncogen. There is a thyroxine supplement after removal of organ, and minimal morbidity is associated with the surgical intervention, and you have a serum calcitonin to follow up this patient. So there are various factors which affect the timings, that is DNA analysis, the age of onset, and the aggressiveness, the lymph node and the distant metastasis. The serum calcitonin is high in the early age, so you cannot have these markers for you, and problems in the thyroid surgery if it is done in early life. So all this, if you can assess here that when you have 918, they have a early nodal and a metastatic disease as compared to the risk criteria A and B, that is the moderate risk. And if you look at the age of medullary thyroid presentation, again in 918, the presentation is very, very early. So depending on that, you have to have also, there is a pheochromocytoma presentation is also different between the two groups, and the testing of a hyperparathyroidism is also different depending on the phenotype and the genotype of the diseases. So the extent of surgery is total thyroidectomy, and we do a central compartment in selected cases only. There is no role of prophylactic parathyroidectomy. And if you look at the medullary thyroid cancer, the presentation in 918 is about 6 months. And if you look at the other cancer, other types, the presentation is about 10 to 81 years or 28 to 59 years and all that. So depending on the presentation and the codon involves, you have to decide when should be the prophylactic surgery should be offered. So in 918, it is as early as 1 year of life. In 883, again, it is before 5 years. In a high risk, that is 634, it is before 5 years. And in moderate risk, it is delayed beyond 5 years. And if you look at the FEO screening, it starts at 11 years and 16 years for the moderate. And if you look at the hyperparathyroidism, it is high risk at 11 years and 16 years for moderate risk. And then you do an annually checkup for this patient. So depending on this, the local long-term results are very good if you do a prophylactic thyroidectomy versus not doing a prophylactic thyroid surgery. The recurrence chances are very high. So age appropriate surgeries are very, very important. And if you see the patient who are operated early, they have better cure rates, and the rate of recurrences are low if they are operated early. These are the various long-term data from the European thing. And if you see the median follow-up, this patient has done very well if they have been operated early, and the chances of recurrences are very low in these patients. We have in Tata Hospital also some group of patients, like 271 patient, where we have actually evaluated this patient, and we got 51 index patient, and we have 52 positive carriers which were positive. Out of that, the most common one was 634, that is seen in 34 patient. And what we saw that when we operated this patient, out of 52 carriers, only 20 patients we could operate. And when we have done a curative in 7 patients, and 13 were prophylactic. Curative means they had some kind of a preoperative thyroid nodules, but they were detected only because of the red proto-oncogene. And when we had done a curative setting, they had a positive nodes and ENE, and they had a larger tumor sizes. But when we had done a prophylactic, we could pick them up in a C-cell hyperplasia, and hardly they had a nodal metastasis. So they were very small foci which we could identify and pick up when we had done the surgery. So there are certain consideration you have to have ethical consideration, that is duty to warn, and parental refusal. When they do it, there has to be some kind of action can be taken by a clinicians, and we need to have this concept when we do a genetic screening for this patient. Also, the reproductive options, what I have narrated just now, the duty to warn genetic risks also extend with this context, and there should be some options should be given to the mother or the parents about this prenatal counseling and the mutation testing. So take home message is genetic testing is essential in medullary thyroid cancer. It helps in prognostication, treatment management, and follow-up. Somatic mutation may help in systemic therapy and a better outcomes in these patients. And reproductive options are worth exploring in medullary thyroid patients. Thank you very much. Thanks a lot.
Thank you, ma'am. That was a very nice talk, very informative. And now I request you to join our case presentation session. Today's case presentation will be presented by Dr. Sameema. She's a MCH resident from TMH Mumbai, and she will be presenting a case of medullary CA thyroid. And the panel of examiners that we have today are Dr. Ratan Shetty. He's an associate professor in the Department of Head and Neck Surgical Oncology, TMH Mumbai. Dr. Kanika Rana. Yes, sir. At Trek Mumbai. And Dr. Kanika Rana, she's a senior consultant, Head and Neck Surgical Oncology, Medanta, Gurugram. And Dr. Amit Tyagi, he's assistant professor in surgical oncology, Delhi State Cancer Institute, Delhi. Welcome, everyone.
Thank you.
Thank you.
Thank you.
Good evening, everyone. So shall I start with the presentation?
Please
Yes,
do.
you can go ahead.
So my patient is a 51 years old female who is a resident of Maharashtra, who is homemaker, presented to us with complaints of swelling in front of the neck since 4 years. History of presenting illness. The patient was apparently normal 4 years back, after which she noticed a small swelling in front of the neck, which gradually progressed in size to reach the present size. There is no history of any associated pain or sudden increase in size of swelling, no history of change in voice or breathing difficulty or difficulty in swallowing, no history of any other swelling in the body, no history of generalized fatigue, no history of heat or cold intolerance, no history of any weight gain or weight loss despite decreased or increased appetite, no history of menorrhagia or amenorrhea, no history of abdominal pain or loose stools, no history of anxiety or palpitations or flushing or excessive sweating, no history of any fever or evening rise of temperature, no history of any non-healing ulcer or pain in the oral cavity, no history of nasal obstruction or bleeding from nose, no history of any exposure to radiation, no history of any bone pain, cough or hemoptysis. Coming to past history, patient is a non-case of type 2 diabetes mellitus and hypertension since 5 years, and she is on regular medications. No history of any other comorbidities, no history of any surgery in the past. There is no significant family history. Personal history, patient is married and she has 2 children. She attained menopause before 5 years, and she takes mixed diet, and there is no addiction history. Summary from the history. My patient is a 51 years old homemaker who is a non-case of diabetes and hypertension for 5 years without any significant past or family history, presented with painless swelling in front of the neck since 5 years, which is gradually progressing in size without any features of any hypothyroidism or compression. Can I go out with examination?
Yeah, Shamima, Ratan here.
Yes.
So, is it typical of a medullary thyroid cancer, the symptoms that you are talking about? How does the medullary thyroid cancer present with?
Sir, it is usually present with a solitary thyroid nodule most commonly, and most of the time the position of the nodule, and also there won't be a much longer history as we see in differentiated papillary or follicular thyroid carcinoma.
Dr. Samima Kanika
Yes.
here.
Yes, ma'am.
Medullary CA patients also have GI symptoms. So did you take history for like diarrhea or
Yes. Yes,
abdomen?
ma'am. I have taken, ma'am.
And
There
that-
is no history of any abdominal pain or diarrhea.
Okay.
Shamima,
Yes, sir.
you listened to the very nice presentation by Anuja Madam.
Yes.
So, what do you think this is? I mean, you should, whenever you present, you should not assume that you should not assume the diagnosis. In this case, you know the diagnosis,
Yes, sir.
but we should arrive at the diagnosis on a history itself. So, are there any pointers which points at medullary thyroid CA?
So first is age of the presentation. Sporadic medullary thyroid carcinoma usually presents in the 5th to 6th decade of life. And if there is a family history, but in this patient, there is no history of no significant family history. And other than that, from history, there is nothing to mention, like to arrive at a conclusion that this can be a medullary thyroid carcinoma.
This is typical of any other thyroid swelling.
Yes, sir.
Isn't
The
it?
most common is always a differentiated thyroid carcinoma, either papillary thyroid carcinoma or follicular, which will be the most common differential as per this history.
This may be a basic question. So, what are the differential diagnoses for a neck mass?
So neck mass, for an anterior neck swelling, the differential diagnosis can be a thyroid swelling, a thyroglossal cyst, or a lymph node like pretracheal or paratracheal mass, or it can be a swelling which extralaryngeal spread of other malignancies such as laryngeal or hypopharyngeal malignancy. For a paramedian swelling, it can be lymph node, it can be a infective or inflammatory node, or it can be a tubercular node, or it can be a metastasis from other sites.
Okay, good. Always try to classify whenever you answer such questions. These are general questions.
Yes, sir.
Okay.
Yes.
Inflammatory, neoplastic,
Inflammatory, yes.
and congenital. Those are the differential diagnoses.
Yes, sir.
Go ahead. Why did you ask for loose stools and abdominal pain? Kanika madam also asked regarding this. Why do you ask for loose stools and abdominal pain?
Yes, sir. So for abdominal pain and loose stools, it can be if in this case medullary thyroid carcinoma, there can be syndromic association, and I have to rule out pheochromocytoma for the abdominal pain, and also in MTC there can be secretion of calcitonin, which can also cause increased gastrointestinal motility, and which can cause diarrhea, which will lead to interpretation that it can be an advanced stage or metastatic disease.
Okay. So you summarize your history.
Yes, sir. So
Moreover, there are a lot of questions to be asked in history itself. So when do you call it familial? When do you call it sporadic? Pointers towards it being sporadic versus inherited cancer.
yes, sir. Sporadic is the most common, around 75 to 80% is sporadic, and inherited is around 20%. And in inherited, there can be a family history. So we should take the family history, and whether if there are more than or equal to 2 family members involved, then we can conclude that this is familial. Or in sporadic, it can be the index tumor case. And also sporadic case usually present later in the life, and inherited usually presents in the earlier life.
What is the age of presentation? The commonest age of presentation? What
Common
decade?
stage for sporadic is 5th to 6th decade of life, and inherited is around 3rd to 4th decade, sir.
Good. And yeah, we'll go ahead. We'll talk about genetic testing and later on because madam had presented that.
Yes.
Summarize your history.
So
Ask,
history,
do you want to
my
ask any questions?
No, I think let's go to the examination first and then we can.
Yeah.
Let her proceed. Sir, let her proceed. She is doing fine.
Yeah. We'll go to the exam.
So examination, the patient was examined after informed consent in a well-lit room in a sitting position. My patient is conscious, cooperative, and well-oriented to time, place, and person. She is well-built and nourished. ECOG status was 0, no pallor, no icterus, no cyanosis, no clubbing or no generalized lymphadenopathy. Pulse rate is 76 per minute. BP is 130/84 in right arm sitting position. SpO2 is 100% on room air. Coming to local examination, there is in neck examination, there is a single smooth globular swelling of size 4/3 centimeter in the anterior neck, extending medially from the midline, laterally till the anterior border of left sternocleidomastoid muscle, and inferiorly up to the suprasternal notch, and superiorly till the level of thyroid notch. The swelling was moving with deglutition and not moving with protrusion of tongue. And skin over the swelling is normal, no scars or no sinus or dilated veins. Lower border of the swelling was not appreciable completely, no other swellings visible, and trachea was central and Pemberton sign was negative. Coming to palpation, my inspectory findings were confirmed with palpation. There is no tenderness, no local rise of temperature. The nodule was firm in consistency, and the swelling was a smooth surfaced globular swelling of size 4/3 centimeter in the anterior neck from midline to the anterior border of left sternocleidomastoid muscle, inferiorly till the suprasternal notch, and it was mobile in nature, and lower border of the swelling was palpable on could negotiate the fingers on deglutition and extension of neck. Rest of the gland was not palpable. Trachea palpated in the midline. No other palpable swelling or nodes. Carotid pulsations palpated bilaterally at normal sides. No signs of hypo or hyperthyroidism. Auscultation no bruit, percussion resonant. And Hopkins bilateral vocal cord were mobile, and other systemic examination were within normal limit. So after examination, my summary is my patient is a 51 years old female who is a non-case of diabetes mellitus and hypertension for 5 years without significant family or past history, with 5-year history of gradually progressing 4/3 centimeter swelling, which is firm in nature and mobile in the anterior neck, extending from midline to the left sternocleidomastoid muscle laterally, inferiorly till the suprasternal notch, without any palpable cervical lymphadenopathy and without any compressive symptoms or features of hypothyroidism or hyperthyroidism.
So what is your diagnosis?
So my diagnosis is like from history and examination, it is solitary thyroid nodule of left lobe of thyroid. So I will like to go ahead with the exam investigations to confirm my findings.
So what are the investigations that you'll ask for?
Yes, sir. So the primary investigations in a thyroid swelling, I'll ask for thyroid function test, especially TSH along with the USG neck as the primary investigation. So TSH, I will look for TSH. If it is normal, if it is decreased, then the patient is in hyperthyroid state. And if it is increased, the patient is in hypothyroid state. In this patient, serum TSH was 2.12. And USG, then next.
Dr. Sharma,
Yes, ma'am.
so what is the significance of TSH? Like, why do you test thyroid function test?
So I would like to know the functional status of the thyroid gland, whether it is euthyroid, hypothyroid, or hyperthyroid. So when a solitary thyroid nodule is associated with hypothyroidism, it has more chances of being malignant. And if it is hyperthyroid, then I would like to go ahead with a iodine scan or thyroid scan. And if, I should know whether it is euthyroid or not.
Any correlation of thyroid function test with medullary or like all cancers, particular cancers, DTC, MTC? So is it a generalized term?
It is
You do this as
especially
part of
for
your
the
generalized investigation, or did you specifically want to look for something? This is part of your general examination, general investigations, right?
Yes, sir.
Serum TSH. Please answer,
Yes.
sir. Okay.
So it is associated with any malignancy, but mostly differentiated thyroid malignancy because
What if you get a low serum TSH? What will you do?
low
Forget
serum.
the medullary thyroid.
Sir?
Forget that this patient is
Yes.
hypothyroid. What will you do?
So,
What will be your investigation subsequent to that? Will you
sub-
poke a plane?
yes, sir. If
You found TSH is low.
TSH is low,
patient-
if the serum TSH is low, then I will go ahead with the thyroid scan. Along with you, I'll advise for USG neck also, and also I will go ahead with the thyroid scan to look for whether it is a autonomously functioning nodule or hot nodule.
Okay. We'll come back to medullary thyroid cancer. So
Yes.
patient is euthyroid. You
Yes.
order an ultrasonography. Are there any features which are suggestive of which is specific for medullary thyroid cancer?
Sir, in this patient,
Not in this patient, generally.
generally, in medullary thyroid carcinoma, the position of the nodule is usually confined to upper junction of upper and middle third or upper pole nodules, and also it will be more posteriorly located.
Why is this so? I mean, do you know the basis? Why does
because
it
medullary thyroid carcinoma arises from the parafollicular C cells, which is located in the which arises from the ultimobranchial bodies, which are located in the junction of upper and middle third of the upper and middle lobe.
Yes, that's the answer. Yeah, go on.
And other features apart from the position in USG, there can be calcifications which is like lobular calcifications are said to be like more in favor of medullary thyroid. Other features we may not be able to differentiate between DTC or MTC.
So this is TYREX 5.
Yes, sir.
You poked a needle in. So
Yes,
what
sir.
are the pathological features of medullary thyroid cancer on FNAC?
Cytological features. Cytological features, medullary, there can be like polygonal or triangular cells, which are, it's a neuroendocrine, so it is just arranged in nest or sheets like. And also there can be like salt and pepper appearance of the nucleus, and also amyloid stroma can be seen.
So amyloid is pathognomonic. And what is the shape of the cells?
It is a polygonal or a triangular cells.
What can you do to confirm your diagnosis on FNA?
So in FNA, if there is any doubt, we can do also calcitonin washout, calcitonin washout in the FNA washout, and we can confirm. And also IHC, if the specimen is, if the sample is adequate, IHC can also be done.
You can do immunocytochemistry.
Immunocytochemistry.
Don't use the right terminology.
Yes.
Okay, so you have Bethesda 6 medullary thyroid cancer. Now, how will you proceed?
So since I got a cytological diagnosis of medullary thyroid carcinoma, I would like to confirm it with the tumor markers. So serum, I would like to go advise serum serum carcinoembryonic antigen. And along with that, I would like to send the patient for genetic counseling, screening, and germline red mutation. And along with that, I would like to rule out other syndromic association. So I will advise serum calcium, serum PTH, and also plasma-free metanephrine to rule out syndromic association. So in this patient, serum calcitonin was 5,866 picogram per ml, and CEA was 40, and calcium was 8.5, and PTH was normal. And the free metanephrine and normetanephrine was normal. The genetic screening is done. There is no family history or anything, and germline red mutation reports are awaited.
So for you, what do you think? This is a sporadic case, or it is a hereditary case? What do you think as per the history?
As per the history and examination, it is more likely a sporadic case. or it can be an index tumor. Since the patient is a 51 years old age, as per age, it may be more likely a sporadic case.
What do you mean by somatic mutations and germline mutations?
Germline mutations are inherited and it is present in all cell types, and the somatic mutations are present only in the tumor tissue.
So what proportion of sporadic cases will have germline mutations?
Around 5 to 6%.
The range 4 to 6%, very low.
Yes, sir.
So what is the inference that you get from serum calcitonin being 5,866 picograms per ml?
So the inference is it is an advanced disease. Serum calcitonin is indicative of the tumor C cell mass. So it is indicative of an advanced disease, and also that can be metastatic.
So what will you do with this report?
With this report,
what other investigations will you ask for?
yes, sir. So if I have to rule out distant metastasis, so I will advise for the imaging workup to rule out other presence of disease in other sites. So as per the guidelines, it says the imaging workup we have to do CT of the thorax to rule out lung metastasis, and contrast three-phase CT or MRI with liver protocol to rule out liver metastasis, and axial MRI or bone scan to rule out bone metastasis.
For every
And
case
for
of
this,
you last with these investigations?
yes, sir.
Calcitonin is 5,866.
For calcitonin more than 500, we will ask for these investigations.
Do you know of any other test that you can do?
Yes, a single best. If we have to do a single best test, then we can do either F-DOPA or F-DOPA scan.
Suppose I don't have F-DOPA, what can you do?
Then I'll go for FDG PET-CT, sir. And
you
in
know-
case of a very high serum calcitonin level, we can go ahead also with the FDG PET scan.
Is there any condition where you will have distant metastasis with lower serum calcitonin?
Yes, ma'am. There is something called hook effect, where there is a very high levels of serum calcitonin. There can be the antibody binding is saturated, and it will not, the immunoassay will not take up the calcitonin. So there can be low calcitonin level despite of having a distant metastasis and gross disease.
And what is the importance of getting a CEA done? Why do you do CEA?
CEA for basal levels, we have to do both CEA and calcitonin. CEA is a marker of early epithelial differentiation, and calcitonin is a marker of late differentiation. So if the CEA is high, it means that it is either poorly differentiated medullary thyroid carcinoma, or it is important in following up of the patient also. Whether if there is any change in poorly differentiation happening or not.
So
What are the histological types of medullary CA?
Yes, sir.
Histological types?
Histological, there are two variants, sir, high grade and low grade, depending upon the factors such as tumor necrosis, where presence of tumor necrosis, then Ki-67 and mitotic index.
So they have values, right?
Yes, sir. Mitotic index more than 5 per 2 millimeter square, and Ki-67 more than 5%.
Okay. What else will you do? Amit, do you want to ask anything?
Oh, sir. Fine, sir.
So what investigation was done in this case?
So in this patient, a CECT head, neck, and thorax was done, and also FDG PET scan was done, sir.
These head, neck, and thorax, and FDG.
FDG PET.
Plain FDG PET or PET CECT?
PET CECT, FDG PET CECT, sir.
Then why did you have to do head and neck and thorax?
Sir, to look for CCT head, neck, and thorax was done initially to look for the local extent of the disease. And we were doing CCT head and neck, so along with that, thorax was advised, and it was to look for the.
Probably they thought that it is, maybe it was ordered during the OPD when patient comes to the OPD, considering the size of the lesion and the clinical
Yes, sir.
feature, assume that it is a differentiated thyroid cancer. Fairly.
So it was initially CCT was done, and then once the serum calcitonin came, like then the FDG PET was advised.
Otherwise, you should not be doing this.
Yes,
Alright.
sir. Yes, sir.
So what is the most common site of metastasis for MTC?
Like liver is most common site, around 45% was considered, and for lungs it is around 33%, and then bone.
Where all will you look for the metastasis?
We'll look for liver, mediastinum, lungs, and bones.
What is the investigation that you'll do to look for liver metastasis?
For liver metastasis, as the guideline says, contrast enhanced MR, contrast enhanced CT, three-phase CT or MR with liver protocol. Also, there are recommendations where it was done, like initially laparoscopic examination was done, because the metastasis which was found in liver was usually miliary, and it is found in the surface. But now, because of advanced imaging technique, it is not recommended in a per primum setting.
Yeah, all this is given in ATA guidelines.
Yes, sir.
So in today's time, and the ATA is quite old now. So what is the investigation that you would be doing? So when would you order a F-DOPA or F-DOTATATE?
Sir, F-DOPA, as per the ATA 2015, F-DOPA and PET scan is not recommended for initial staging. But latest NCCN also recommends individual site specific imaging, or it is they have recommended either a gallium DOTA scan or PET scan.
Okay, so I ask you, when would you order that?
Yes, sir. In a recurrent setting where the serum calcitonin is increasing, then we will ask for DOPA, and if CEA is increasing, then PET scan is more better.
Can you scroll through the imaging? Only in recurrent metastatic. Okay. Can you scroll through the imaging?
This is a contrast enhanced computer tomography of the neck and thorax. Where initially we can see the normal structures, this IJV, carotid, sternocleidomastoid, thyroid cartilage. We can start seeing the appearance of the thyroid lobe, where the left lobe is enlarged with heterogeneous enhancement. And also there is a disease in the tracheoesophageal groove. There are some nodes which can be seen in the paratracheal central compartment. And also there were level 4 nodes, and also there was level 2 nodes in the left side. Level 2 nodes which can be seen in the left side.
So was this patient REC mutation positive?
Sir, the genetic screening was done. The patient got operated last week only. This genetic screening is done, and RET is awaited, sir. Reports are awaited.
So what is your indication to go for a REC mutation screening?
Sir, in MTC, the guideline says all patients with MTC requires RET mutation analysis.
Suppose this is a question that I wanted to ask. Suppose your RET mutational patient's age is around 25-30.
Yes, sir.
RET mutational analysis has come negative.
Yes, sir.
Can it still be a familial malignancy? I mean, familial syndromic malignancy?
Is if the RET mutation analysis comes negative, then one thing is we have to do the whole genome sequencing. Even if that is also negative, then we can call it as sporadic.
Anything else?
As per the guidelines now, they don't advise for further screening or this thing because that is the advantage of doing RET germline mutation. If it is negative, we can call it as sporadic.
Okay, the patient has a family history of thyroid malignancy. The first degree relative, can you do any test on the first degree relative to look for medullary? Or
Yes, sir. Carriers, the family first degree relatives have to be looked for any like carriers, red carriers, and then if that is negative, then again following up of the patient with further screening, annual screening, and all has to be discussed with the family.
do you know of this? So we don't have pentacrastin in India. So do you know of this pentacrastin test or calcium stimulation test? So when is it indicated? Is it routinely performed now?
No, it is not routinely performed. It is said that IV calcium or pentagastrin can increase the sensitivity of the calcitonin, but it is due to the discomfort and the side effects. It is not recommended routinely. And right now, the immunoassay which is used for calcitonin is highly sensitive, so it is not recommended.
It's not recommended. Or when is it recommended? In what condition is it recommended?
Not sure, sir.
You read about it. That's the reason I asked this question.
Yes, sir.
Patient is fitting into familial. The first degree relative, also genetic analysis is negative.
Yes.
We can do a pentagastrin or a calcium stimulation test.
Yes, sir.
So beyond what value will you consider it as positive?
Beyond 10.
And this is theoretical because I personally don't have any experience in this.
Yes. Beyond 10 is considered as.
No. Read about it. All right.
Yes, sir.
Okay. Go ahead.
So there was no metastasis and the diagnosis is medullary carcinoma of thyroid left lobe. Staging is there was since there is a in the CT scan there was association trachea. There was a Shin grade 2 association with the trachea, but the bronchoscopy and the upper GI scopy has shown normal. So it is CT4A and 1B and M0.
So for all of us, can you describe what is T1, T2, T3, T4?
Yes, sir. T1 is divided into T1A and T1B. T1 is less than 2 centimeter, but not more than 4 centimeter without extrathyroidal extension. And T2 is more than 2 centimeter, but not more than 4 centimeter without extrathyroidal extension. T3A is more than 4 centimeter without extrathyroidal extension. T3B is with the gross extrathyroidal extension into strap muscles. And T4A is gross extrathyroidal extension involving recurrent laryngeal nerve, trachea, larynx, or esophagus. And T4B is involving carotid sheath, prevertebral fascia for skull base.
Do you routinely do upper GI scopy in case of thyroid?
No, sir. In this patient, the scan was showing there was a loss of fat plane with the esophagus and trachea, and also it was involving the tracheoesophageal groove. That is why it was done.
In your history also there was no symptoms, right?
No symptoms, no symptoms.
So do you still feel that there might be involvement, mucosal involvement or something like that?
Yes, sir. Without symptoms also it can be there.
Mucosal involvement of the esophagus.
No, mucosal involvement of esophagus is very rare. Usually if it is involved, the muscular involvement will be there. To involve mucosa, it is very rare.
It has to be outside to inside.
Yes, sir. From muscular layer to inside.
Okay, so
okay, please.
Yeah, go ahead.
Sir, please. She can continue.
You go ahead, you go ahead.
So
Sir,
how
I'm
does
done.
serum
I'm done.
calcitonin, Tamima, so how does serum calcitonin levels affect your surgical management?
Serum calcitonin level can decide the extent of surgery. There is by Meckens et al. There is they have given the values where we can decide on the extent of the neck dissection. So it is incorporated into ATA guidelines also. If there is more than 200 serum calcitonin, then we should do contralateral lateral neck dissection also. More than 20, it is ipsilateral and ipsilateral central and ipsilateral lateral. More than 50, it is contralateral central, and more than 200, it is contralateral lateral. And also, if it is more than 500, there may be a mediastinal or distant metastasis.
Okay, so for this patient, what will be your line of management?
Yes, ma'am. So this patient had a medullary thyroid carcinoma with a serum calcitonin of 5,000, and also the scans were showing nodes in the central compartment and lateral compartment. So I will go ahead with total thyroidectomy with a bilateral central compartment clearance and bilateral neck dissection.
As per your scan, there was a shin too, right?
Yes, Shin 2.
So what was done for the trachea in that case?
Trachea in that case, there was plain, and so it was shaved off from the trachea and from the esophagus also, but there was no gross residual left.
So was it really Shin 2?
No, intraoperatively, it was not really Shin 2, sir.
Okay, so what is Shin 1, 2, 3, 4? It is a pathological classification which has been adapted into this.
Yes,
So
sir.
what is Shin 1, 2, 3, 4? Can you describe it?
Shin 1 is just abutting the perichondrium. Shin 2 is erosion of the perichondrium. And Shin 3 is transmural, transcartilaginous, but not involving the mucosa. And Shin 4 is transmucosal.
So why did you call it Shin 2 on imaging?
Yes, there was some
Looked like it was breaking up.
There was some irregularity seen, sir.
If you are in
Just
doubt,
may I make a comment?
any other investigation?
One is bronchoscopy to look for any mucosal involvement, and for esophagus we can go ahead we can go ahead with the MRI, or also we can do EBUS.
Okay. So what was the extent of surgery that we did in this case?
It was total thyroidectomy, bilateral central compartment, and bilateral neck dissection level 2 to 5.
So do we have the pathology report?
No, sir, it's not yet reported.
Okay. So you talked about the paper on the biochemical guided neck, surgery.
Yes, sir.
So how many papers are justifying it, substantiating that? That's so one paper.
So there are multiple papers, and recently there are like upcoming papers from like studies from MSKCC where they have observed the neck also. If the like only therapeutic neck dissection was done, the prophylactic lateral neck dissection was not done.
So what is the minimum surgery that you do in a medullary CA thyroid?
Minimum surgery as per the latest NCCN, it is total thyroidectomy with the central compartment clearance.
And
Yes, sir. As per like in our practice, we do the neck dissection, but the latest NCCN says total thyroidectomy with central compartment clearance and therapeutic neck dissection if clinically or radiologically node is there, and
what if the
ipsilateral.
central compartment nodes are involved?
Yes, sir. If the central if there is a
100%
gross
infection is positive.
ipsilateral neck dissection, sir.
So always assess for the central compartment nodes.
Yes, sir.
Doing a contralateral neck dissection, even when the ipsilateral neck nodes are negative, may be an overkill. So does it have any bearing on your treatment outcome?
Like not doing contralateral, sir.
Yes.
Yes.
Yes, sir. If the calcitonin levels are too high and the nodal burden in the central compartment is high, then there can be high chance of recurrence. So, going ahead and doing a reoperation, it is better to do the neck dissection, considering the chance of recurrence with the.
Are you sure about your answer?
No, sir.
Do you want to reconsider? What is the survival that you see with the stage 1, stage 2, stage 3, stage 4 medullary CA thyroid?
So stage 1 to 3, the survival, 10-year survival is around good survival where there is 90 to 93%. But for stage 4, the survival is low. It is around 30 to 40%.
So,
Is there any chance that if this patient had distal metastasis, then would you have still gone for the same procedure or something else?
Yes, if there is distant metastasis, the medullary thyroid carcinoma is basically a surgical disease. So I will go ahead with total thyroid. I will go ahead with the surgery, and then depending upon the whether the patient is symptomatic for the distant metastasis, and based on the serum calcitonin and CEA value, I'll go ahead with the further treatment.
no,
What is
what
the
madam
rationale of operating? Sorry, you go ahead.
yeah, what madam wanted to know was if patient had a over distant metastasis, would you have done a bilateral neck dissection when the neck nodes are negative on the opposite side?
Yeah, the burden, the surgical morbidity can be reduced. Still, the surgical morbidity, if there is no nodes if there is no nodes, then we can go ahead with like total thyroidectomy and central compartment clearance. And therapeutic neck dissection can be done only if there is a gross disease. The idea is the surgical morbidity can be reduced if there is already a overt distant metastasis.
You always stick to your answer. And secondly, there is no consensus on whether you should do a prophylactic neck dissection on the opposite side. There are groups which do prophylactic neck dissection to achieve biochemical cure, and there are groups which we can avoid doing a prophylactic neck dissection. All right,
Yes.
but there is no consensus on whether you should do a prophylactic neck dissection on the opposite side. When the ipsilateral is also negative, then I don't think you should be going ahead and doing a prophylactic neck dissection on the contralateral side.
Yes, sir.
Okay, suppose you have left behind gross disease. It is SHIN2 and you have shaved the disease of the trachea. What will you do?
If there is a gross residual disease, always the preference is for the surgical removal. And if it is not surgically resectable and it will add the morbidity, then what we can advise is adjuvant RT. So the indication for adjuvant RT is if there is a gross residual disease and gross extrathyroidal extension and high volume disease.
Always try to achieve surgical cure. All
Yes.
right.
Yes, sir.
Don't leave behind disease in medullary CA thyroid unless it is adding to the morbidity, especially when there is distant metastasis.
Yes, sir.
Other than that, I don't think you should be doing shaving and all that.
Yes, sir.
In this case, I think we have achieved R0 clearance.
Yes, yes, sir.
All right. So what are the indications of what you talked about radiotherapy? What are the indications of radiotherapy in medullary CA thyroid?
Yes, sir. Indications, there are no actual consensus, but it is indicated in situations like where there is gross macroscopic disease which is left behind, and also if there is a gross extrathyroidal extension, and also high nodal burden and high nodal burden, and also this is indication for adjuvant ABRT, and if there is metastasis, then like palliative RT can be considered.
What
Is
is
there
your
any
experience with medullary CA plus DTC? And if you find that, is there any change in the treatment?
Yes, ma'am. So if there is a coexisting differentiated thyroid carcinoma, then depending upon the tumor, like the volume, whether it is predominantly differentiated thyroid carcinoma, then as per the stratification, we can consider for postoperative radioiodine treatment also.
And what is the incidence of like getting a mixed biology, mixed tumors?
Incidence, I'm not sure. I'm not sure, ma'am.
And suppose this patient was red positive, then do you have anything else in your armamentarium?
If this is red positive, then the family counseling has to be done and the first degree relatives have to be counseled, and red mutation has to be tested to look for carriers. And also if it has implication in the prognostication, and also if later if the patient has any recurrent or metastatic disease, then it can also guide treatment with systemic therapy.
How do you assess response to treatment, Shamima?
Response, we will assess postoperatively after 3 months, we will assess serum calcitonin and carcinoembryonic antigen, and also local physical imaging such as ultrasound. So if the calcitonin and CEA is undetected or undetectable, then we have attained a biochemical complete cure. If there is increasing serum calcitonin, or if there is more than 150 picogram per ml of serum calcitonin, then it is indicative of that there is some residual disease or metastatic disease. Then accordingly, the workup has to be done to rule out structural disease.
All right. So does the calcitonin doubling time have any bearing on survival?
Yes, sir. There are calcitonin doubling time indicative of the aggressiveness of the disease. If it is less, there are different studies which says different duration. So if the calcitonin doubling time is more than 24 months, it is said that the disease is stable and stable. And if it is the calcitonin doubling time is less than 6 months, then it has got a very aggressive nature.
Yeah, you should talk in terms of survival. 5 years, 10 years survival.
Yes, sir.
If the calcitonin doubling time is less than 6 months,
the survival,
do
yes.
you expect the patient to survive 10 years?
No, sir. That's 5-year survival. 5-year survival is also like around 28%, 28 to 30%.
What if the calcitonin doubling time is more than 24 months, that is 2 years, what is the survival?
Survival is like 10. We can talk in terms of 10-year survival, sir.
Yes. How good is it?
10-year survival is if more than 24 months, it is around 90% survival.
And what is the survival for a stage 1 medullary CA thyroid?
93%, 93 to 95.
98%.
98. Yes.
All right. This is a fairly indolent disease when compared to squamous cell carcinoma. So don't treat medullary CA thyroid as bad as a squamous cell carcinoma. But there are aggressive variants, and these aggressive variants need to be treated. So does adjuvant RT improve disease-free survival?
No, sir. There are no studies which can say that adjuvant RT improves.
I asked specifically, before committing your answer, think disease-free survival, not talking about overall survival.
Okay. Disease-free survival, I'm not sure about the.
So you should be aware of all the studies which are looking at adjuvant RT in medullary CA thyroid, especially in stage 4 disease.
Yes, sir.
So what is the recommendation for adjuvant RT? Consider EBRT is the recommendation. So when will you consider EBRT? In what all conditions?
Adjuvant EBRT, sir. Adjuvant EBRT, it is like as per ATA guidelines, it is recommended for gross residual disease and gross extrathyroidal extensions.
Yes, the strength of the recommendation is low, but you can, if you are left behind disease, then you can give adjuvant RT. Suppose there is structural disease and it's a large volume disease, and surgery would entail a morbid surgery which will compromise the airway, compromise the recurrent laryngeal nerve. You can advise EBRT.
EBRT, yes, sir.
So suppose you find a small nodule in the neck and the calcitonin level is rising and you are able to localize. So when you plan surgical treatment in a recurrent metastatic setting, what are the factors that you would consider?
So factors is one is the resectability of the localization of the recurrent or metastatic disease, and then whether and also the serum calcitonin and CEA levels and the doubling
Volume of the
time
disease.
and volume of the disease and the patient's general the performance scale and the distant volume of the distant metastasis. Then if the disease locoregional disease is surgically resectable, then the first priority will be for resurgery and clearance of the disease. And for metastasis,
Patient is not symptomatic.
yes, sir.
You are able to localize, the lesion is quite small, patient is not symptomatic. The calcitonin doubling time is also more than 24 months. Do you want to jump into surgery?
Sir, if the calcitonin is in increasing trend, then we will, and if the disease is accessible for surgery, then I'll go ahead with the surgical exploration. But if if there is a disease like either in the mediastinum or where surgical accessibility is less and the patient is asymptomatic, then I will not go ahead with surgery.
So do you expect to achieve biochemical gain in your patient?
Sir, no more than 1,000 picogram per ml achieving achieving complete biochemical cure is not possible. So most of the time it won't happen.
So what proportion of patients will achieve biochemical cure if it is less than 1,000 picogram per ml?
Sir, less than 1,000, it is said that like almost like not all complete, but a major patient can percentage as such, I don't remember, sir. But more than 1,000, it is said that achieving is not possible, but less than 1,000, it can achieve complete biochemical cure.
You should know the ballpark figure. So what proportion? Half of them will achieve biochemical cure.
Yes, sir.
So there is dynamic stress stratification in medullary thyroid cancer. So how do you follow up with medullary thyroid cancer? Based on risk stratification.
Yes, sir. So first follow-up will be after 3 months with the serum calcitonin and CEA. And then we will see for the values. If it is undetectable, then biochemical cure is achieved. And then if it is less than 150, and then if it is less than 150, again serum calcitonin and CEA is repeated after 6 months and 6 months. And also the USG neck will be done. And if there is, and then again we will see for the trend in serum calcitonin and CEA, and this is continued for 1 year, and then annually is we follow up annually, and then we'll look for the doubling time and whether the serum calcitonin is stable or not.
So if you
Earlier,
sir, please.
please ask your question. I have asked too many questions, I think.
Sir, it's okay, sir. Please, you are my teacher, sir. Please.
Yeah, I mean, please go ahead and ask what
If there is a carcinomembranous antigen is raised, could it be possible that calcitonin may be normal in post-op follow-up?
Yes, sir, it can be possible where serum calcitonin can be either normal or low and serum CEA can be increased. So it is indicative of the poor differentiation of the disease and high advanced stage of metastatic disease where there is poor differentiation.
So what you offer to such patients? So is there any role of chemotherapy or anything?
Yes, sir. There is a role of systemic therapy, but it is indicated when there is a symptomatic and progressive disease. Symptomatic and progressive disease with or evident structural disease, then systemic therapy is recommended. And also it depends on the first line drugs are vandatanib and cabozantinib despite of the RET mutation or the mutational status. If it is a specific RET mutation, the selective RET inhibitors can be used.
Namely,
Sulpercatinib.
do we know the trial which established sulfacatinib as the
Yes, sir. It is Libretto 531 and yes, sir. Libretto trial.
Yeah, good. Is there any drug which we can use in very advanced medical thyroid in neoadjuvant setting?
Neoadjuvant setting.
Are there any drugs which are being studied for that? There is no established evidence for this, but are you aware? You have answered well.
Sir, I'll read about it. I've read, but
Suppose you have a small nodule in the central compartment, and surgery will entail dissection of the central compartment in recurrent setting. You may injure the recurrent laryngeal nerve. Can you do something other than operative surgery?
we can go ahead with radio frequency ablation or
Patient
cryoablation.
asymptomatic.
Patient is asymptomatic. So we can look for the trend in serum calcitonin level and we can observe the patient, or non-surgical management, then we can go ahead with the RFA.
So when do you do F-DOPA?
F-DOPA, when there is a rise in serum calcitonin level in the follow-up period, then we can go ahead with F-DOPA.
Do you know of any therapy?
Yes,
Like
ma'am.
neoadjuvant medicine therapy?
Yes, ma'am. It can be either DOTA therapy, lutetium, or PRRT therapy, or DOTA FAPI therapy can be done, which is radionucleotide therapy.
So are they like the recommended therapy? When do you do them? When the role comes?
The PRRT, actually it is not recommended in a routine setting, but if there is a unresectable progressive disease which is not amenable for surgery or not amenable for systemic therapy, then we can consider for PRRT.
So in a man syndrome, when you plan for total thyroidectomy, in case of that
Yes,
is fostered.
Yes, sir.
In case of man syndrome, when you plan for total thyroidectomy, if it's RET foster in the family.
Yes, sir. For men to be when there is 918 mutation, the prophylactic thyroidectomy is indicated within the first year of life. And for high risk like 883 and 634, it is before 5 years. And other moderate risk, it can be based on the serum calcitonin and CEA levels, and it can be delayed beyond 5 years.
And when do you go for screening of pheochromocytoma?
Pheochromocytoma screening is done for the high risk. It is done at 11 years of age, and for moderate risk, it is started at 16 years of age.
Sir, Ratan sir, please.
Yes. We have how much time do we have? We have another 10 minutes. So there are a lot of questions on the chat box. CA high and calcitonin normal. What is your interpretation?
Yes, sir. If CA is a marker of early differentiation and calcitonin is a marker of late differentiation. So if CA is high and when calcitonin is either normal or low, it means that there is a advanced metastatic disease where there is a poor differentiation of the disease.
So there is a question from SCPGI. Iodine 131 MIBG therapy as a adjuvant therapy in residual disease. we don't have much experience regarding this, and there are case reports. I think the reports are not very much in favor of using this uh, as a therapeutic drug in recurrent metastatic disease. Now, coming to the another question, increased calcitonin in 100 and 1000 has different implications. I mean, it has to be we should be given a context as to how we can interpret that. Role of
I think
prophylactic.
she has answered, sir, the doubling time. Probably that's what we are asking.
And Gopi has asked any low risk mutation, Shamima.
Yes, yes, sir. There is in the latest NCCN there is like low, like less risk patient category which is given, which is like 8
The risk stratification is
and
highest, high, and moderate, right?
highest, high and moderate, sir. But
So what is the low risk mutation that you know of?
sir, in the latest NCCN they have given some like low to like less high risk category, which is like highest is 918, highest 634 and 883, and the rest like 609, 618, 620 are moderate, and there are some in like 809. I'm not sure about the number, which is low risk.
Low risk.
No, not exactly low risk. It is the term is given as low to moderate. I will read about it, sir. But as per the ATA, it is highest, high, and moderate.
Gopi can put the answer up in the chat box. I'm not aware of any low risk. All right. Suppose you get a report that the margins are positive. What will your treatment be?
Margins positive. So first thing is whether we have left behind gross residual disease or not. Otherwise,
Margins are positive. You have left behind at least an R1 disease.
yes, sir. R1, then we will follow up the patient, sir. If there is R2 gross
Will you
residual
go for
disease, we
second
can-
look? Will you go for second look?
Second look, we will follow up the patient with the serum calcitonin and CES, sir. If it is in rising trend, then and also we will do the imaging, and then if there is structural disease, then we will go ahead with the second look. Otherwise, we will keep the patient under observation.
So you have heard of that ethanol injection therapy that is there. Has it
Yes.
any role in medullary CV?
Yes, sir.
Ethanol injection therapy, therapy that you have heard of it?
Yes, sir. In like DTC, when there is a residual like disease just over the tracheoesophageal groove, and if it is likely to cause nerve palsy when already the opposite side is palsied, then or in the benign setting, but no, in MTC, I'm not sure about the role, sir. Radio frequency ablation I've heard, but ethanol injection I'm not sure.
How
I
will
think
you
there are-
manage hyperparathyroidism if you have along with
Yes, yes, ma'am. So,
MEN2A.
like if it is a single adenoma, then we can excise, and if there is multiglandular disease, it is said that we have to leave at least one parathyroid equivalent mass, and which has to be auto transplanted in the non-dominant brachioradialis.
So what is the kind of hyperparathyroidism that you see in medullary MEN2A?
Sir, it is not, it is either mild to moderate hypercalcemia which is seen, not a severe one.
Right. So you talked about theranostics and all that. That is lutetium PRRT therapy. Now coming to questions on the chat box. All that has been discussed. So Shamima, so how will you follow up your case? You have described how will you follow up your case.
Yes, sir. So this
Is there any
patient,
role of, is there any role of RT in your case?
in my case, sir, it was an R0 resection. Now I will wait for the histopathology report. If there is high volume nodal disease or gross extrathyroidal extension, I'd like to discuss with the multidisciplinary team and to take a decision. But mostly in this patient, since it is an R0 resection, I won't be going ahead with the EBRT.
Suppose you have left behind gross disease, then there may be a indication. There definitely is an indication for H130, but in this case, I don't think there is any indication for H130. And H130 decreases disease-free survival, it decreases recurrences, but has no bearing on overall survival.
Yes.
So if this patient had mediastinal nodes, then how do you manage? Do you like to do a mediastinal dissection at the onset?
If there is a mediastinal node which is either which is like surgically resectable and there is no other distant metastasis, it is only in the mediastinum. If there is no other overt metastasis like in lungs, liver or bone, then I can plan for a like sternotomy and the mediastinal node clearance along with the surgery.
And if there are distant mets, then?
Then I will not go ahead with mediastinal because it requires sternotomy and the patient, the morbidity maybe increase. So I will not go ahead with a morbid procedure when there is already a gross disease, distant metastasis present for the patient.
Yeah, good. Shamima, never do morbid surgery when there is distant metastasis. And the question on the chat box regarding prophylactic thyroidectomy, I think that has been described by Anuja madam in the class. Do you want to reiterate that, Shamima? When would you do a prophylactic thyroidectomy?
Yes, sir. If
risk?
there is a red germline mutation in M918, which is MEN2B, then prophylactic thyroidectomy is indicated within the first year of life. And when there is 883, when there is 883 and 634 mutation, it is indicated before 5 years of life. For moderate risk mutation, it is indicated, it is delayed beyond 5 years and the patient is followed up with the serum calcitonin and CEA level, and depending upon that, the thyroidectomy can be done.
So, but when would you do a prophylactic thyroidectomy in a moderate risk patient? You ever doing a prophylactic thyroidectomy?
When there is a and there is and we will be doing the annual examination and serum calcitonin. If there is any increasing trend or if there is any localization, then we can go ahead with prophylactic thyroidectomy. Or if there yes, sir.
Teenage years.
Yes, teenage.
You can never doing. You don't have to do. What is the problem with doing pediatric thyroidectomies?
The one thing is identification of parathyroid gland will be difficult. So there are chances of permanent hypocalcemia. So that is which adds the morbidity. So that is the problem with the thyroidectomy.
Okay. So when do you screen for pheochromocytoma in highest risk, moderate, and high risk?
In high risk, pheochromocytoma screening is started at 11 years of age, and in moderate risk, it is 16 years of age. And for hyperparathyroidism also, like a high risk, it is 11 years, and a moderate risk, it is 16 years.
Why don't you see MEN2B patients, Shamima? What is the reason why we don't see MEN2B patients?
Because it is highly aggressive and like the patient may not be alive to present with the symptoms. It is highly aggressive.
Very rarely you do see them, but very rarely you see them in adulthood.
Yes, sir.
Unless it has been detected in. Why do we want to do medullary CA thyroid surgeries in RAT mutations?
Because we want to prevent the disease progression and we want to prevent the recurrence. So that is why we do prophylactic thyroidectomy.
Yeah, when you do a medullary prophylactic thyroidectomy, avoid development of medullary thyroid
Yes, sir.
and save
And-
life. When is the when would pheochromocytoma manifest in MEN? 2A and 2.
Pheochromocytoma, it is usually manifested at like 3rd to 4th decade. Yes, sir.
Yeah, good.
3rd to
You have done very well.
It is usually manifested in 3rd to 4th decade, sir.
Asim, should we continue? It's 7 o'clock. I think Shamima has done answered very
The
well.
last few questions can be asked and then we can conclude.
Is there any role of hemithyroidectomy? Do you want to answer that question?
Yes, sir. So in RET negative nodule,
You
which
did not
is,
have RET report when you are planning surgery for a medullary CA thyroid.
then I will
So
not
what
go
would
ahead
you
with.
have is a calcitonin report. So
Yes, sir.
I had given an opinion on when we would do a hemithyroidectomy. Suppose you have done a hemithyroidectomy thinking that it is a solitary thyroid nodule and the report has come as medullary CA thyroid and your calcitonin value is less than 20, then you may not have to
Go ahead with
do a
completion. Yes, sir.
and
Completion.
you do a genetic testing and genetic testing comes out to be negative. There is no genetic mutation.
Yes, sir.
Only then you do a hemithyroidectomy. Otherwise, the minimum surgery for a medullary CA thyroid would be a total thyroidectomy with central compartment clearance.
Yes, sir.
I think that should answer the question. Anything else, Asim? Role of theranostic and its implications. Shamima, you have answered that question.
Sir, all questions has been addressed. But otherwise,
Yeah. So I would rate Shamima very highly. She has performed very well in the presentation. She has answered almost all the questions except for the very difficult ones which I had to read about. Very good.
Yes, sir. She's performed really well.
Really well.
And it was a very good discussion on medullary thyroid cancer. And thank you everyone for joining. So we'll meet
Thank you.
again with another topic.
Thank you. Thank you.
Thank
Very
you
well,
for the
Shamima.
opportunity.
Thank you everyone.
Bye, Sunena. And
Thank you, sir.
thank you, Anuja madam.
Thank you, ma'am.
Okay. Thank you, everyone. Goodbye.
Thank you, Dr. Kanika.
Thank
Thank
you.
you. Thank you, sir. Thank you.
Thank you,
Dr.
Amit.
Thank you, Sunana.
Yeah.
Thank you, Amit.